coronavirus, where we will be looking specifically at both cancer care, but also very much concerned with the return and impact of both elective surgeries and the impact that our second wave may have on this. We have two sessions today. The first is specifically focused on cancer care. I am delighted to be able to welcome with us today Cancer Research UK, and we have Emlyn Samuel. Thank you so much, Emlyn, for coming. From Breast Cancer Now, we have Mia Rosenblatt. Mia is the Associate Director of Policy and Influencing at Breast Cancer Now, so thank you very much. And I should have said Emlyn is the Director of Policy. And also we have, I'm very delighted to be joined by Dame Laura Lee, who's the Chief Executive of Maggie's Cancer Support. So thank you all for being with us today, and I'm going to dive right in. We've got lots of questions from our parliamentarians, and my first ask actually of everyone is to be as concise as possible, so that we can fit as much into this time as we possibly can. So starting with Emlyn, then Mia, and then Dame Laura, could I simply ask, what are the issues that your organisation has witnessed over the course of the pandemic?
Thank you, Leila, and thank you very much for inviting me and Cancer Research UK along today. I will try and be concise, but what I thought I'd do is take you through a bit of the journey. So what happened in the immediacy in terms of the first, the lockdown, where we're at now, and some of the considerations of where we are now and looking to the future. So if we think about the kind of the immediate impact of the pandemic and what that had on cancer services, had a considerable impact. If we look at some of the figures, we saw that patient presentation to their GP when people had signs and symptoms of cancer really dropped, and we saw a real big drop in the number of referrals into the NHS from primary care, and that was as much as a 75% drop in some cases, which simply meant people weren't going to their GP with their signs and symptoms and then being referred into the service. We also saw cancer screening services paused officially in Scotland, Wales, Northern Ireland, and de facto paused in England. Meaning that people weren't being invited to screening during that time, and we also saw many diagnostics and treatment services put on hold. In many cases for valid reasons, because of patient safety, and I think that's an important message to get across, that a lot of decisions were taken in the interest of patients. But it has caused a huge amount of disruption. And then also a vast majority of clinical trials paused to recruitment during that time as well. 95% of Cancer Research UK's clinical trials paused to recruitment, and figures show that recruitment to trials dropped by about 87% in that period. So we're talking kind of April, May time here. But if we look to where we are now, there's been a huge amount of effort put in from across the health sector to get services back on track. COVID protected safe spaces for cancer care have been set up across the country. Public awareness campaigns are working and encouraging people back into the system, which is really encouraging. And the latest cancer waiting times from England that were published last week show that we're pretty much back to pre-pandemic levels in terms of those indicators. So in terms of that urgent referral, that's now above what it was this time last year. However, there's some detail within that. It's better for some cancer types than others, and there are areas such as referrals for lung cancer which continue to lag behind, which is really worrying. But cancer screening services are getting back up and running, and so are trials, albeit quite slowly. So while it's encouraging that we're looking at back to kind of pre-pandemic levels in terms of those indicators, what it does mean though is that there remains a significant backlog in terms of the number of patients yet to come into the system, but also in the system. because the service will need to run over 100% of what it was doing previously to clear the number of patients that weren't coming into the system during that period of time. So we estimate that around 3 million people weren't invited to screening during that period of time. About 400,000 people were not referred for diagnosis during that time. There were over 3 million fewer diagnostic tests, and thousands of patients, over 30,000 patients didn't start their treatment in comparison to a previous year during that time, and many patients missed out on clinical trials due to the pausing. So it's encouraging that we're back to that level, but there is a substantial backlog to still clear. And the real worry here is that we're going to be seeing more people. Well, a lot of people haven't been diagnosed with disease during this period, and there is a real worry that we'll see more people diagnosed at a later stage because of this backlog, and that is a considerable worry in terms of the outcomes that those patients receive. Looking at where we are now, as a second wave is hitting the NHS, the signs are that people are still continuing to present to their GP, and that's really, really important that we continue to maintain that uplift and that progression. But we are seeing in parts of the country where COVID is most prevalent, real impacts on capacity in particularly in diagnostics and treatment services, which is a worry. It's absolutely vital that we learn the lessons from the first wave, and that we protect cancer services through this second surge and beyond. It's absolutely critical. And there are many things that have been put in place, as I mentioned, the COVID protected safe spaces. We're really encouraged to see that the government is now rolling out twice weekly testing for all patient-facing NHS staff, which will really, really help. We need to maintain those public awareness campaigns, and we need to protect the services and the trials at the same time to ensure that we can continue the progression to recovery and transformation beyond that.
Thank you so much, and we'll certainly be returning to many of those themes, I know, in the questions that we've got. Mia.
Thank you. I'll give a kind of view from a breast cancer more specific angle, but I, absolutely agree with the points that Emily's raised there. And as you say, I think some of the detail, I'll give quite a headline, but we'll come back to that as well. So for breast cancer, coronavirus is the biggest risk that breast cancer has faced in decades, and the impact has been felt across the breast cancer pathway. I'm going to give a bit of an overview on some of the key issues faced. So for diagnosis, at the height of the first, we saw a big drop in the number of people being referred to see a specialist with suspected breast cancer. The routine screening programme was effectively paused. And while referrals have improved and the screening programme has resumed, we believe that the impact is likely to be an increase in demand for diagnostic and imaging services in the coming months, with a significant impact on an already overstretched workforce. That is a really big area for us, the impact on the workforce at the moment. And I'm sure we'll come back to that in more detail as well. In terms of treatment and support, many patients' treatment has continued and changed, but other patients saw delays and cancellations to their treatment alongside changes to the support they received. This has caused huge levels of anxiety, particularly for patients with incurable secondary breast cancer and their loved ones. And, I really want to make the point that while, we will rightly focus a lot on diagnosis today, and that is absolutely essential, it's so important that we don't lose sight of the impact of coronavirus on people with secondary breast cancer and secondary cancers. This community really often feel that their needs are forgotten, and they should be front and central in the conversation about the impact of coronavirus on cancer, and equally in the government and NHS England's plans moving forward. We really passionately believe that. Guidance published earlier this year by NHS England and NICE suggested how patients should be prioritised for drug treatment if this became necessary. Patients having non-curative treatment, such as those with secondary breast cancer, were generally given a lower priority than curative. This was hugely concerning and something that we raised with governments and the NHS, who did reiterate the importance of decisions being made on an individual basis according to the risks and benefits of treatment. But the extent to which this guidance has been used in practice is unclear. It's essential that the needs of secondary breast cancer patients are identified and addressed in cancer recovery plans, including recognising the absolute importance of drug treatments for these patients. You know, at the moment, unfortunately, our understanding of the true impact of coronavirus on patients with secondary breast cancer is going to be hampered by the lack of available data on this group, including even the number of people actually living with the disease. It makes it extremely difficult to plan services at the best of times. And that's why part of, you know, what Breast Cancer Now at the moment are calling for in terms of comprehensive spending review is an audit on secondary breast cancer. And finally, I would just echo Emlyn's point as well about the impact on clinical trials being paused. And again, you know, this was something that people with secondary breast cancer really felt passionately about and were deeply concerned about, because clinical trials represent for many their hope, a future, and the pause of those trials had a really big impact on many people. You know, research that Breast Cancer Now and other medical research charities fund has also been impacted by the estimated drop in charities' income. And I think, you know, it's clear that without further action, there is going to be a gap for years to come as well. So that's just a brief overview on issues, but hopefully we'll get later. Thank you.
Thank you, Mia. We will certainly come back to many of those issues, and I know many of them are also shared by Maggie's. Dame Laura.
And has so eloquently described, and Mia, Maggie Centres, we have 24 centres that are based on cancer centre grounds that provide psychological and emotional and practical support to people with cancer. So we've been very much at the end of people experiencing the cessation of palliative chemotherapy, the cessation of clinical trials, and alterations to their treatment pathways and the delays of coming through the system from their and being seen by their GP and being seen in the hospital. What our staff, and I have a background in cancer nursing as well, but all of our senior clinical cancer nurses and clinical psychologists have said that we know in the best of times cancer is hard. It's a complex disease with very many complex treatments and consequences of the disease. But what coronavirus has done is brought, it's heightened many of the experiences that people with cancer talk about, and it really sort of falls into sort of 4 themes. I think our staff have said that they have not experienced the level of anxiety and distress in people affected by cancer. It's absolutely profound. And as they came through the first lockdown, that anxiety has shifted into anger, of feeling like they've been forgotten, and feeling an increased anxiety about the impact of this second wave is having on their altered treatment. We've seen a huge impact of people presenting with advanced disease. It's already coming through the system. I think, Emlyn, you mentioned about the impact on lung cancer. And we know in our Nottingham Centre that lung cancer has increased by 22%, those that are presenting with advanced disease. And that's impacting on their emotional impact of having to deal with the fact that they are presenting with incurable cancer. Bereavement has been a huge impact as a result of the lockdown. So people have had to experience losing someone that they loved because of the cessation of their treatment and not being able to be with them. So bereavement work has become much more complicated and complex as a result. And the financial impact of coronavirus, people with cancer are not immune to cost of cancer itself is expensive, then losing jobs and work on top of that. And our benefits advisors have seen over 16,000 people that have accessed them for additional help and support in terms of the financial impact. And I think this level of fear and anxiety is not cessating at all, and is continuing to remain at very high levels because of this unmet need of the advanced disease group that are coming through. Hand it back to you, Leila.
Well, thank you very much all for those précises. And my first question, and perhaps we'll do it in reverse order. There is quite rightly, a lot of consternation right now about the impact of coronavirus on people not presenting, not going to GPs. It's very heartening to hear that some of these numbers are going up again, but they obviously need to be balanced by what you've just described, Laura, of the anxiety of those who are suffering with cancer and their families. In terms of the balance between, do we, in this second lockdown, is this the right thing to do to get on top of the virus versus the worry that people have about delayed diagnoses and problems that we're storing up down the line? Where do you see that balance lying? What should the government be trying to do? Should they be prioritizing cancer care and elective surgery, very cognizant of the long-term effects of not doing those? Or should they be prioritizing on stamping down the virus in the short term? Where is that balance, in your opinion? Laura, and then Mia, and then back to Emlyn.
It's obviously a very fine balance, and it's not that the community that Maggie supports don't understand the impact of COVID and the need to protect the NHS and to keep people safe. But there is a feeling that they have been forgotten in this process, and I think we have to strike a balance for making sure that we consider the long-term impacts of this. So when you think that we could take as long as 15 years that some people are articulating to get back to 2019 survival rates, the long-term cost over the short-term actions of this are really very significant. And then you've got a medium-term impact of this increased anxiety and distress in what is a large population of people who before COVID, 450 people a day approximately would die of cancer. So for them, they're used to living with death being a daily consequence as a result of their disease. So I think that we need to continue to find a balance for keeping cancer referrals into the system and treatment going. And that means that we need to encourage people to go and see their GP. We need to make people feel that they're going to visit their GP and visiting the hospital is safe. We've had many people who, because of the government's messaging, have not even gone in for their cancer treatments because they have felt that they should also stay away from the hospital. So we need to change that messaging.
Thank you very much. Mia?
Thank you. I mean, this is a very difficult one, isn't it? And I think it's worth bearing in mind that we have learned a lot since the first wave as well. I think at first some people's treatments were stopped not because of capacity, but because of concerns of immunity or who was going to be more vulnerable to the virus and how we manage that. I think we are clearer on which groups are affected now. But I guess I would say, we need to see cancer services continue this time. We really need to not stall again. We can't afford to pause again. But I don't see it as an either or situation, and I don't think that it is about lockdown per se. If the rate of coronavirus increases and becomes uncontrollable, that will affect the health service. The continuation of breast cancer services depends on keeping coronavirus under control as well. So, I think it's not, we should see it more as managing coronavirus will help us to have a health service that can support other areas too. And therefore, I think a focus on lockdown as part of the problem perhaps takes us on a slightly a path that perhaps confuses things. And more the question is, how can we best focus on keeping coronavirus manageable and keeping other services on the road at the same time, which we need to do. And I think there is recognition that we need to keep cancer services operating as much as we can, as can be done at the moment. And I think, there is a difference perhaps at the beginning of the first wave on that.
So not either or, but and.
Exactly. Yeah.
It's
definitely it's the value for breast cancer. There's value for cancer patients by controlling coronavirus. Absolutely. Also, cancer patients are at risk are at risk of coronavirus themselves, and keeping the infection rate low is valuable to cancer patients, not least when it comes to services that they may or may access for cancer too. So. Thank you.
Emlyn?
Yeah, I would agree with all that, actually. I realise there's a balance strike, but we absolutely need to be able to control the virus, because as we've seen from the numbers of the impact that it had on cancer care in wave one, we absolutely need to try and control that, bring it down so it doesn't have that level of impact again. At the same time, as Mia said, we've learned a lot of lessons about how the service reacted and has put measures in place to bring the service back, and we absolutely need to maintain those. So the balance here is that, yes, we need to control the virus, and as Mia rightly said, some cancer patients are particularly vulnerable, and if they catch COVID, it could be very detrimental. So we need to balance that with protecting cancer services in the NHS. The government has committed in all 4 nations as well to protect cancer throughout the COVID pandemic, and they need to absolutely back that commitment. The setup of COVID protected spaces, the increase in testing is really encouraging. We are starting to see increased sickness rates and things like that, which is putting even more strain on services. And fundamentally, there's a lack of capacity in cancer care that existed pre-pandemic that does need to be addressed. But there are other ways as well that the service can continue to protect cancer services, including through use of the independent sector as well. And so, there is that commitment there to protect cancer during COVID. We saw what happened in wave one. Huge lessons have been learned. We cannot go back to a state like that. And we absolutely need to protect cancer service through this second wave, and continue on that trajectory of recovery, because as I mentioned before, there's still a very large backlog of people and patients waiting, and we absolutely need to work hard to clear that in order to protect patients and give them the very best care.
Thank you very much. So I'll now throw this to Paul Strasburger. We've got 6 parliamentarians who have very important questions to ask, and we have around 20 minutes to do that all in. So just to ask if we can keep it very brief, and if someone else has said something you agree with, feel free to sort of pass on, and I'm confident that we will cover all the major issues. Similarly, parliamentarians, if your question has been answered, I would appreciate it if you would say so and either ask something else or move on. Paul Strasburger.
Thank you, Leila, and good morning to you all. We've partly discussed this already, but can we be a bit more specific on it? How have COVID-19 restrictions and reduced access to services impacted diagnosis and support? And in particular, are patients presenting with more advanced cancers, and what impact is that likely to have on survival rates? Perhaps Emlyn, you go first.
Sorry, was that me?
Yes, please.
Yes. Oh, sorry, I missed that. Yeah, so I've described already the impact that it's had on diagnosis from a number of angles, the reduction in number of people coming forward with signs and symptoms and the pausing of cancer screening. So that has absolutely had an impact on the number of people coming through the system for a diagnosis, and that absolutely needs to be cleared. We don't have, as I said up front, and Laura mentioned earlier, we are really worried about the fact that people will be starting to present and are presenting with later stage disease. An early diagnosis of cancer is absolutely critical to improving survival outcomes. And we're hearing anecdotally that more people are coming in with advanced disease. And that is really worrying, because that could lead to a knock-on impact in terms of our survival outcomes and patient survival outcomes in this country. We don't have the data to show us that yet, for sure. And I realize that there have been quite a few different studies out there projecting and modeling the impact on survival. But from Cancer Research UK's perspective, we're waiting to understand and see the data. For example, there is data on stage of presentation, which will tell us, what the impact is, and then we can understand what the survival impact will be going forward. But but we don't want to. We want to wait until we see that evidence before we make firm conclusions. What I will come back to is that diagnostic services in the NHS are significantly under-resourced and have been for many, many years, both in terms of staff capacity, but also in terms of equipment. And as Mia said, the spending review coming up is a really critical opportunity for government to invest heavily in the diagnostic element of the NHS. Because that is going to be really critical, not just to shifting the dial in the current situation, but also to transforming cancer outcomes in the future.
Thank you. Laura, have you got anything to add to that?
Yes, I would say that from the work that goes on in our centres, our staff are reporting a significant uplift of those that are coming into the centre with more advanced disease. In part, it's as Emlyn has said, it's quite hard to sort of track how far COVID has impacted in that. But there is also some data around 50,000 people who have not presented, who would normally have come through the system this year. And we can only assume that as they start to come through, that they will present with later disease. But from the centre staff specifically, an increase in people coming in for emotional support, having been told that their disease is at an advanced stage and that palliative treatment options are, and it's varying between 10 to 20% across our different centres. I would say that the centres in the north of England have been the worst affected. The London centres that we have certainly had a better cancer, a sense of that cancer services have continued in the hospitals environments. But we've, again, over the last few months, last few weeks, we've had surgeries delayed again in Nottingham and Liverpool, and that's certainly flowing through into the support requirements for the staff, the patients and family members that are coming through. And I think it's been particularly significant for the family members because they've not been able to go into the hospital, join any of the consultations, and so they're sitting there without actually really understanding the impact of COVID on their loved one's survival pathway.
Thank you. Mia, anything to add?
Thanks. Yeah, I'd just say from a breast cancer view, between March and September, there were over 98,000 fewer referrals by a GP for tests compared with the previous year. And we've estimated that a backlog of nearly 1 million women built up across the UK prior to screening programmes restarting. So in terms of attending routine screening appointments, and in terms of diagnostics more generally, women who already have a diagnosis of breast cancer may have missed scans too, such as to check whether people with secondary breast cancer, whether their cancer has progressed or not. That will have been impacted in terms of access. So while referrals and the routine have improved and the routine screening programme has restarted, there are changes to the way the service is now operating, which could have consequences for some time to come as well, particularly for the routine screening programme. The move away from timed appointments to open appointments, we expect that is going to significantly decrease the number of the expected number of attendees for routine screening. I think when it comes to breast cancer, it is going to take us years to fully understand the impact on outcomes. Routine screening obviously often picks up cancers at a very early stage. We will see cancers come through for people who miss screening in years to come as a result, and it will take us a long time to really understand the impact on this, and equally so not just at the first wave, but now once the screening program's resumed, if less people come through that would have done for that cycle, we'll feel the impact of that for a long time.
And although I understand you don't have the data yet and it's going to take a long time to come through, would you expect the impact on outcomes to be significant?
I think I definitely think that, yes, there will be an impact on outcomes. I think the extent to which, I guess, will depend on, for the routine screening angle, how many people do now take up appointments and how much we see that happening. I think how much we, as Emlyn said, how much do we invest now in diagnostics urgently to make sure that we are resourced to see people? We're not going to be able to catch up unless we seriously invest in this area. And we hope that the spending review will be able to do that, not just for single year, but for multi-year. because the diagnostic workforce was under significant pressure prior to COVID. So now, you add on all of this, we are going to see those impacts. And I think there's a lot of things that we will need to unpick, potentially from across, increased deaths of people with cancer because of COVID during this time. How does that affect, deaths from cancer in future years, to delayed diagnosis in future years and deaths in future years? Some people, it might be that people don't present for cancer for some time to come, for breast cancer for months or years to come. So it will be a long time before we get a true picture of the impact.
Thank you. Thank you very much. Back to you, Leila.
Thank you. Thank you very much. Caroline Lucas.
Thank you. I know we're under time pressure, so I just want to pick up, I guess, something that several of you have talked about indirectly, which is around staffing, and you've obviously talked about the impact in diagnostics of having a under-resourced workforce there. But could one of you maybe just give a bit of a picture about how much of an issue, if at all, staff shortages have been in your areas? I'm thinking as a result of doctors having to self-isolate, or medical staff waiting a long time for tests. How has that impacted, if at all, this sector? Maybe Emlyn, do you want to go first?
Thank you. So as I mentioned before, yeah, diagnostic services and staffing in diagnostics were, there were lots of shortages. I think about 1 in 10 vacancies in diagnostics pre-pandemic. The pandemic has only exacerbated the issues in this space, primarily because that staffing group is under even more pressure to diagnose the many conditions that are coming around. And diagnosis is absolutely critical for cancer, but of course it's critical for many other diseases too. So it's under pressure from the weight of people that we need to diagnose right now, but it's also under pressure. Coming back to the point around sickness, we are seeing more and more. It's inevitable, isn't it, that the staff are having to self-isolate, staff having to ensure that they are protecting their patients. And that's where testing is really, really critical, and why we're really encouraged by the announcement that twice weekly testing for patient-facing staff is now being rolled out. And that doesn't just go for staff in hospitals, but also in primary care as well, because we know that GP practices are under significant pressure as well. So it's absolutely vital. We need the investment in the long term to increase the number of staff that we have. But in this period, we absolutely need routine testing of staff. So there aren't people who are self-isolating for no reason, given, if they didn't have COVID, and we can maximize the resource they have. Sorry,
do you have any figures by any chance about what percentages of the workforce at any given time recently have been out of the workforce because they're self-isolating or waiting tests or whatever?
Only from what I saw from the government's own press conference I think it was a couple of weeks ago, that it estimated that about 30,000 staff were off sick or self-isolating, which is a substantial number of staff that in an already very stretched NHS.
I don't know if anyone else had anything to add, but otherwise we'll move.
I would just like to add in about the emotional health and well-being of our cancer centre staff. Again, much of the work that our centres provided during the lockdown period was our psychologists supporting staff. And I think if we're going to be part of the cancer recovery plan, it's about making sure that we look after our cancer centre staff who are at the cold face of having to deal with the catch up, but also seeing how it's impacted on people's lives as they're presenting with pretty challenging scenarios as a result of later diagnosis. So I think it's a thing for the future, but it's a staff health and well-being is a vital point.
Thank you.
Thank you very much. If I can now go to Baroness Masham.
Has government guidance on shielding or easing of restrictions been sufficiently clear for patients and those who they live with? If we could have an answer for all three, because this is a very very important question for people who think they should be shielding. If all three of you an answer, please.
I'll go first. I think the initial shielding was frightening and daunting for people, and it was something that both the person who was asked to shield and their family members actively sought support, and of course that was then provided online and digitally. What happened when we got to the end of the first lot of lockdown is I think they weren't adequately guided as to how to come out of that shielding process. They were scared and anxious, and they didn't know where to go to feel safe. So I think we could have done a better job of helping people make that initial transition. As we moved into the second lockdown, I think there was an absolute fear that they were going to get this letter again, and that what that would mean for their emotional health and well-being and how to sustain themselves through a second lockdown. So I think that we, although they understand the purposes behind the shielding letter and welcome the guidance from the government, I think we could do a better job of helping people come out of the shielding process and help them move back into a society in a safe and timely way.
Anything more other panelists want to add in addition?
Yeah, I guess I would just say, I think, it's not always, it's not necessarily a straightforward answer to this information, as the guidance has changed repeatedly during the time. And, I think, as has been expressed, there's been a lot of anxiety from people about the guidance. There has been concern at times about how the shielding guidance was communicated, that changes to shielding was not always as clear as it could be. I know there have been efforts to improve this, though, and recognition of the need to improve it. Our sister charity Blood Cancer UK have done a lot of work on this issue across the sector, leading on the sector, and continue to do so. So, I think what's really important moving forward in the second wave of the pandemic and beyond is that any changes to shielding advice are clearly communicated and cascaded effectively as well, and that people are really supported to receive relevant emotional, practical and financial support services.
Thank you very much. And what about Emlyn?
I don't have a huge amount more to add. I agree with Laura and Mia on a lot of these things. I can just say, in terms of response to, the Cancer Research UK runs a helpline and provides a lot of patient information and support. And we did have quite a significant uptick in number of calls at the beginning of the initial pandemic, and concerns about shielding and what it means for family and loved ones, as well as patients themselves. That seems to have fallen off a little bit, and we're seeing some calls still come in, but clearly it is very anxious, an anxious time. And I think I would just agree in terms of the communication going forward that it's absolutely critical we get this right.
There is one problem, which is travelling to treatment if they don't drive, and having to use taxis or public transport. That can be a problem.
Yeah, thank you very much. I'm afraid we're going to have to move on. Lord Russell.
Yes, just if I could ask each of you very, very briefly, if you think of if you distill the lessons that we learned in this first wave down to let's say the three most important lessons, are they being applied now? Have we learned from them? And that's we means the government as well as your organizations. Are we actually applying the lessons that we've learned in an appropriate way? So if I could start off, please, with Dame Laura.
I think what's been helpful about this time is that there's been no question that Maggie centres can stay open and operational and continue to provide face-to-face support. And that has been a huge relief to the people that we see in our centres, that digital support it fills a gap, but it's not sufficient, particularly at this point. So that's been really helpful. I think my one thing for the messaging around the NHS is that we need to find a way of not just saying that the NHS is open and that GPs are open, but it's also a safe place for people to come and receive their cancer treatment and have their consultations. And I think if that was the bit that I would shift, is that We need to help people come into the system, as opposed to, at the moment, people are very fearful. And interestingly, they'll come to a Maggie centre in the hospital grounds and feel safe in a Maggie's, but they don't feel safe going into the hospital. And I think we have an opportunity going forward to address that.
Thank you. Mia, please.
Thanks. Yeah, I think there is a real emphasis, it feels, at the moment about keeping services running, keeping referrals going. I think, which we've learned the lesson from. There was a big drop in referrals, and the message has gone out from NHS England to really encourage people to keep coming forward for that, which is really important. I think some of the if the NHS does face the pressure it did previously about what the prioritisation guidelines that might come out from that are not completely clear at this point. We would really like to see a focus on supporting people with secondary breast cancer as we move forward, and continue to do that, and how we can keep treatment going for people. So I think that's a really key area for us moving forward. But I think that there will also been some innovations that have been adopted really quickly during the pandemic, which might not have been as quickly adopted previously, such in terms of radiotherapy, where research showed that actually, you can give, you can look at giving the same treatment over 5 days instead of 3 weeks in more intense doses, and it would be as effective. And the NHS moved really quickly on that, which is great. We need to keep those innovations going as things revert back in some ways to old systems. So it's really important to keep the positive stuff, as well as trying to address what has been more negative during this time, negative impact on services.
Thanks. And very briefly, Emlyn?
I guess building on that, the three things I would say is: one, cancer services needed protecting. There's a big lesson, and patients need confidence in those services. And I think that is one huge lesson that we learned from wave 1 that I think is being taken forward in wave 2 through the development of COVID protected spaces, the testing agenda, all of that sort of stuff. And as I said, we need to absolutely maintain that. We absolutely need to protect cancer services in wave 2. Second, just picking up on Mia's point, there's been a huge amount of effort to reorganize services, to run services differently, and some innovation has come from that, which we should look to embed. And there are some good lessons there. And then the third thing, I think it's only heightened the resource issues associated with cancer services. It's really come to the fore that we need more staff, we need more equipment, not just to cope with the pandemic, but to improve cancer survival in the long term. And on that third point, we're yet to see a shift from government, and we're hopeful that the spending review will provide that shift.
Thank you. Message received loud and clear, and we'll add our names to that call, I'm sure. Barbara Keeley, I should add, we are now on borrowed time, so as quickly as we possibly can. Thank you very much.
Well, I think Emlyn led into that question. Thanks, Lola, and thanks to all the witnesses. My question is, what support from government is urgently needed now and in the future? Emlyn, I think you're making a bid for staffing and equipment in the comprehensive spending review, but what else? What other support is urgently needed now?
When I go first,
Laura, yeah.
I would say that we need to embed in psychological and emotional support for people with cancer. We've been moving to a culture of encouraging people to self-manage their care, but clearly with the impact of COVID and the nature of what will be quite long-term effects, and we need to make sure that patients and their families are adequately supported, both psychologically and emotionally, not just out of the COVID period, but I think there's an opportunity to embed that so that we can actually look in 5 years' time to actually think that we care for our people affected by cancer better than what we did when we went into COVID.
Okay, thank you. Mia?
Thank you. Yes, I mean, as I've said and Emlyn said, we really echo the workforce point and investment, and also investment for clinical nurse specialists as well. We know for people with secondary breast cancer often don't have access to a CNS, and it's really, really important that we invest so that everybody does, and that we invest in having a secondary breast cancer audit, as I mentioned in the intro. But more broadly, I think that we continue to invest in medical research. The Association of Medical Research Charities has a call for match funding for charities for research investment and for the spending review. And I know that the medical research community backs them strongly in this call. And I hope that an opportunity to support further research will come through that. Research has reduced and suffered as a result of COVID in the area in cancer, and I think how to put ourselves back on track and how do we move forward is really important. Thank you.
Emily, you've already made a bid, haven't you?
I have, yes. Workforce and kit, particularly in diagnostics, is absolutely what we're hoping to see come out of the spending review in terms of the NHS. But just building on Mia's point, in terms of, there's lots of stuff that we can do to improve cancer care right now and in the near future by just implementing things that we know work well. But we're not going to achieve really substantial change in improving cancer survival without medical research and without continuing to invest in medical research. And just speaking from Cancer Research UK's point of view, and we're working very closely with the Association of Medical Research Charities on this, the financial impact of COVID has meant that we've had to cut 44 million out of our budget this year already. We've not been able to fund a new clinical trial this year. And that financial hole is only going to deepen as we have to look to reduce our spending by about 150 million in future years because of this financial hole. And ultimately that will hold back progress for patients in the future. We really don't want to have to do that. And we are working with others across the sector to seek some financial support through the spending review from government to protect this vital medical research. And ultimately, it's all part of ambitions as well to be a world leader in life sciences and a superpower in science that can really benefit health and wealth of the nation in the future.
Thank you. Thanks, Chair.
Thank you very much, everyone. We have only gone 5 minutes over, which I think was some great achievement, actually. But I thank you all for joining us today. It's been certainly illuminating, your oral evidence now, your written evidence before, and if there's anything you felt that you weren't able to cover, please do write in again, or if anyone watching feels compelled to write in, please do that. I'm now going to move on to the second panel, and thank you all for again joining us. If you wish to stay and listen to the second panel, you're very welcome, although I obviously appreciate you are very busy people and may need to head off to somewhere else. So Emlyn Samuel from Cancer Research UK, Mia Rosenblatt from Breast Cancer Now, and Dame Laura Lee from Maggie's Cancer Support. Thank you all, and thank you to your organisations and your staff for everything that you're doing in this very, very difficult time. Thank you.
Thank you.
Thank you. So I'll now move on to the next panel, just 6 minutes late. And with permission, I'll go slightly beyond 1 o'clock so we get the full time because it's an incredibly important panel and very much linked to what we've just heard. And we're going to be focusing on the impact of COVID-19 on non-COVID care, what some call elective care, although no doubt the patients who need that care don't consider it something that's optional. And so we have a very knowledgeable panel. We have Saffron Cordery, who's the Deputy Chief Executive of NHS Providers. We also have Neil Mortensen, who's the President of the Royal College of Surgeons of England. And we have Dr. Edward Morris, who's the President of the Royal College of Obstetricians and Gynaecologists. So thank you all so much for being with us today. And I'll start in the same vein as I did with the first panel. If you could perhaps start by just taking us through, from the perspective of your organisations, what have you seen happen to non-COVID care over the course of the last few months? And perhaps if I can sort of add to that, we know that there is a concern with the second lockdown that elective care and non-COVID care may be pared back if we aren't going to see the reduction in COVID cases that we're hoping to see. Can you take us through what you think that's going to look like? Is that already happening? And to what extent should we be concerned that that's happening as we speak? So let's start perhaps with Saffron.
Thanks so much, Layla, and thank you very much for inviting me and NHS providers to talk to you today. Just briefly, NHS Providers is the membership body for all types of provider trust in England. So we span hospitals, mental health trust, community services and ambulance services. So we're not just focused on hospitals, which I think is an important element that we should all take on board in thinking about COVID. I suppose if I just briefly focus on wave one of COVID and then move us into what happened post wave one and where we are now. In terms of wave one of COVID, I think it's fair to say for everyone, this was an unknown challenge and an unknown quantity, but for the NHS in particular, it posed an unprecedented threat, in a sense, to the services that were being provided and the populations that it served. And the focus for all providers really at that point was how they could shift capacity, think about how they could manage the workforce challenges, which included increased sickness absences, of course, self-isolation, the need to redeploy the workforce. There was a real focus, as we all remember, on the supply and shortage of PPE and how that was going to get to staff to keep them safe and to keep patients safe, increasing infection prevention and control measures, testing and the development of test and trace. So all of this really intensive activity that took place at the beginning of the first wave. And then also critically thinking about the balance between elective and non-elective care and managing some quite important localised estate issues, including things like the supply of oxygen. And I think it's quite important that we remember, thinking about it now, how intense all of those elements were and felt during the first wave, because the whole service was literally learning as it went. You know, we haven't encountered a pandemic like this. So it was very much about identifying new challenges on a week-on-week basis and working out how to overcome them, both in the short and the medium to long term, so that we had a service that could provide that elective as well as non-elective care. And I think it is really important to remember that although it was challenging in the first wave, the NHS didn't shut down entirely for non-COVID care. Emergency care was there, some cancer care did continue, but it's fair to say not at the volumes that it had previously. There was an intense period of activity after the first phase of COVID. So as we moved out of that kind of big peak, and we came down the other side, and the R rate went right down, and you know, by July there was a kind of loosening and lifting of the lockdown measures. The NHS provider sector in particular was focused on restoring services for all physical and mental health trusts and patients across the board, and that meant increasing cancer and elective activity, and also, and I think this is really important and this gets forgotten, is managing the ongoing surge in mental health demand. And I'm going to purposefully focus on both of those because I think that it's something that's been massively out of the media spotlight in particular. And it's really important that we remember that non-COVID care includes mental health care and community services. During the summer, the NHS was set a very challenging target, which it did actually meet, which was to restore the volume during that time, the volume of non-COVID work, so elective work, to 80% of what it had been at that time in the previous year. And they did actually meet that target. It was hugely challenging. Nobody thought that providers would actually do it, and they did. So there was very fast work to overcome the very particular challenges of both the backlog of COVID, but also what it means to actually practice during COVID. So although, sorry, I've just realised that my cat has woken up. Apologies for that. So during COVID and beyond COVID, infection prevention and control, absolutely critical. That caused some substantial challenges. I think wave two feels different to us in many ways, both positively and negatively. So the capacity challenges I just alluded to, including social distancing, managing hot and cold sites, the delays built in by infection prevention and control, but the fact that the NHS has actually now established really new ways of working to manage this, including changes to how treatments are delivered, redesigning pathways, virtual appointments where possible, and of course for many NHS staff, home working wherever possible. And this is absolutely critical when we're thinking about managing treatment whilst also making sure that NHS staff on the front line don't put themselves and their patients at risk. But I think that we have to remember that the legacy of the first wave of COVID and what we're dealing with now is workforce burnout, fatigue, extreme challenges, exacerbated by the need for staff to continuously self-isolate if they test positive, but also the compliance with social distancing, the compliance with infection prevention and control does actually really reduce capacity to restore services. And that is a reality. And you only have to watch the BBC Hospital programme to realise quite how far-reaching this is. But what the NHS is doing really to innovate where it can. I'm going to stop now.
I'm terribly sorry to have to move you on because we do have a lot of questions that will dive into more depth. And also for other panelists, if someone has said something that you agree with, please, I implore, don't repeat it. Just say that you agree with points already made and then make new ones if that's at all possible. So if I could go now to Edward Morris.
Thank you very much, and thank you for the invitation to give evidence today. Really appreciate the opportunity. So I'm going to answer things split by pregnancy and also gynecology, because I think that's probably the best way to illustrate the differences. So with regards to the initial wave of the pandemic from a pregnancy perspective, so we mustn't forget that pregnancy is one of the hospital's third front doors. It is something that you can't stop. Pregnancy has continued during the pandemic, and we've had to change how we look after pregnant women. At the college, we produced guidance to begin with to help pregnant women and also providers understand how best to deliver care in a changing environment. And we've had 12 versions of that guidance during the pandemic to account for the changing environment we found people in. And this has been a massive uptake nationally and internationally. Millions of people have looked at that, and it's turned out to be extremely helpful. But if the direct effects of COVID on pregnancy, thankfully in the UK, those have been managed relatively well initially, but what we're starting to see is some of the indirect effects, so the non-COVID effects, as this APPG is talking about today. And I think that we can concentrate those into areas of staff shortage. So we were already starting with a relatively poorly supplied workforce, and a letter from the Royal College of Midwives, I think, has gone out today to that effect. But that was compounded by the effects of redeploying maternity staff from maternity care into other areas of care where they thought they would be needed urgently during the first wave of the pandemic. Then the other factor is the change in behaviour of women. Understandably, there were concerns and worries about the virus in the community, and there were concerns about picking up the virus by coming to hospital. But in addition to that, not wanting to bother a seemingly stretched health service with their pregnancy concerns. And we've seen evidence that some women have presented late with pregnancy complications. And we're just starting to collect data about whether these indirect effects on pregnancy have had a significant effect on outcomes. And there is a small amount of evidence that there could be a small increase in the number of stillbirths. And you'll be aware that the Healthcare Safety Investigation Branch have started to look into some cases to see if we can get more details. My college are trying to do a wider look at the data of other outcomes that could be relevant to at the moment. So if that's the short answer to the pregnancy issue. With gynecology, which is the other half of our specialty, we've seen, as was said before, a significant reduction in activity during the first wave, which affected both cancer and non-cancer gynecology, with pretty much a cessation of services. Cancer started to come back on stream somewhat quicker than non-cancer services, as trusts prioritise cancer services appropriately. But it appears that as things are coming back to normal, and as a college, we worked with NHS England to produce a document on restoration and recovery of services, which is an immensely useful thing across all the colleges to be involved with. And that has been helpful, though my college are particularly concerned that it seems as though the non-emergency care, so the elective care waiting list for gynecology, is not being shortened as quickly as other specialties. And we're concerned that it may be that pressures in trusts are not seeing that women's health is as much of a priority as perhaps it should be. Women are 51% of the population. A slow increase in activity in gynecology could mean that tens of thousands more women are waiting, and it may look a small number, but it could be very significant, because these are often young women with problems such as chronic pain, endometriosis, fibroids, heavy periods, who are unable to work because of their problems and have been on a waiting list for a very long period of time. I'm aware, having listened to the panel earlier, that you're going to ask some questions about other areas, so I'll stop answering at that point and then contribute later on.
Thank you very much. Yes, we certainly will. Professor Neil Mortensen.
Hello, everybody, and thank you again from me for the opportunity to speak to you. And I won't repeat, I'll try not to repeat what the other panelists have already told you. As far as surgery is concerned, about mid-April, most planned surgery came to a grinding halt. In view of your previous panel, I do want to say that in terms of treatment for cancer, of course, surgery is a very important part of it, and much of cancer surgery has continued. There was a brief pause, there was some modification of treatment protocols, but mostly cancer surgery treatment has completely recovered and is continuing successfully. However, that leaves all the non-cancer stuff, and as you'll be very, very aware, there is a massive backlog. In the early stages of the, if you like, viral surge, there was a lot of fear amongst surgical staff about what sort of procedures were dangerous or not. Some of the early deaths amongst surgical staff from COVID were those looking at noses and throats, for example, and that's still one of the big backlogs of planned surgery. I'll go into some numbers in a second. So there has been a recovery, and like my colleagues, we've given guidance on the recovery. We helped the NHS with a major prioritization document which tried across all specialties to fairly decide who should have first, if you like, priority in any particular situation over their particular type of surgical need. And that's been very, very useful. But of course, it's left a big tail of people in the lesser priority areas who haven't had a chance of having their surgery done. If I just give you an idea of the patients waiting over 52 weeks, the biggest group is trauma and orthopedics. 31,000 people waiting over a year now, and they may be hips and knees, and those patients may be having to get in a wheelchair or have painkillers at night now. The next three groups are ear, nose, and throat surgery. I mentioned that because everybody was worried about the possible aerosol spread of the disease. Then general surgery, ophthalmology, although we don't represent them, oral surgery, urology, and then gynecology, which Ed has mentioned already. So we have this massive backlog, and we don't know how we're going to quite manage it. We have been arguing all the way through for ring-fenced COVID-light sites. In those, if you like, lucky trusts who have a separate site for their planned surgery and, if you like, another facility which doesn't in any way get mixed up with their emergency admissions, mostly those institutions have managed to keep going to a greater or lesser extent. It's where it's all mixed up in the emergency facility, it's much, much more difficult to have what we call green pathways or COVID-like pathways in an acute hospital, especially when the prevalence of the virus rises it's incredibly infectious. It's very difficult to keep it under control. You can have a supposedly COVID-like ward, and then bang, it goes down with an infection. The ward has to be closed, or at least closed to planned surgery or other, if you like, clean medical problems. So COVID-like sites are really important. We have got to the point now where we've got testing, which is absolutely brilliant, and we hope that will make a fantastic difference. The other area which we haven't really talked about, which has been a big change, of course, has been the recruitment of the independent sector. So those independent sector beds have been absolutely invaluable. For example, where Layla is an MP in Oxford, where I work, all the breast cancer surgery was done in the private hospital. And that was fantastic because there was absolutely no stop to it at all. But in other places around the country where there's no independent provision easily accessible, or where there's no COVID-like site, there has been obviously a major effect on the ongoing supply or provision of surgical services. And I think the other thing that we need to mention at some stage, in the craft specialties, where you need to do cases to get up your numbers, to be signed off, to eventually qualify as a surgeon, this has had a massive, massive impact. So there's a whole generation, what we might call the COVID generation of surgical staff, whose lives have been very, very, very badly affected by this. And we don't know how they're going to get off the end of the training program. If you can imagine it rather like a conveyor belt with people getting on at one end and coming off at the other. If they can't come off at the other end, how can the new people get on? Can they come off at the other end if they haven't actually got the adequate experience? This is a huge, huge problem, which we're really, really worried about. So I'll stop there for now.
No, thank you very much. And I've got a quick follow-up about where we are now, because as I know from Oxford University hospitals, but I'm sure they are not unique to others across the country, there is a moment where they're already beginning to start rolling back elective surgery that they had restarted because of the concern about the number of COVID cases that particularly are going to swamp ITUs, but also, you know, the main hospital, because fewer and fewer people are now going to ITU, but the main hospital itself. I wonder, actually, Neil, do you have numbers to suggest how many people are already rolling back on elective surgery that they had restarted, or is it too soon to tell how big this problem is in this current lockdown?
Not actually, no. I mean, we know certainly of probably 10 to 15 trusts around the country where that's already happened. Obviously, around Liverpool, that's happened in a big way. In the northeast, around Leeds, Nottingham, Birmingham now very badly affected. I can't give you the exact details, but those are that's a sort of rough picture.
Thank you very much, all of you, for your opening statements and answering my question. Caroline Lucas.
Thank you, Layla. I just had a very quick question, building on what I think, Saffron, certainly you touched on about staffing. I wanted to ask you how much COVID has exacerbated existing staff shortages, and in particular around either burnout or the issue of staff having to self-isolate or go through testing and so forth. What has that impact been on top of what I understand has already been a level of concern about staff shortages?
Really, it's a very pertinent question. I mean, we asked our member trusts about 6 weeks ago how concerned they were about burnout in their staff, and over 90% were concerned about the impact of fatigue and burnout on their staff as a whole. So it's a real and present issue for staff. We know that the workforce was in a fragile position before we came into the pandemic, over 100 or approaching 100,000 vacancies. So that's an already kind of weakened situation, as it were. We know that the thing about self-isolation is that it's a deeply frustrating element of this. It's really important that people do self-isolate, but the lack of adequate testing so that tests can be turned around quickly if someone in a household is infected but not the NHS worker themselves is deeply frustrating because it takes them away from the front line. We need to see that changing as fast as possible. We know that turnaround in, say, pillar 2, which is the general key worker community testing, is particularly slow. So that really needs to be improved. But in terms of your overall question, whilst we saw a number of staff return into the NHS with that call to arms early in the process, I think what we have seen is some key shortages, which has caused real pressure. So if we've got people who are unwell with COVID, community prevalence will suggest that NHS staff will fall in line with the prevalence. So if it's 1 in 85, we can expect at least 1 in 85 NHS staff, if not more, due to their exposure, to fall down with that. Then there's also self-isolation. And on top of that, we're looking at a workforce that has been working incredibly hard for a sustained period on the back of coming through a really difficult winter, difficult summer before that, and a difficult winter before that. So yes, it's a challenging situation. But I'd say that the NHS always does and will continue to rise to the challenge, and they've done that by working differently and innovatively. And so that's one of the things, I think Neil touched on this to an extent, but different ways of delivering services can help with all of those elements. So it's not all doom and gloom. We are learning a lot from this pandemic, but staff shortages and burnout don't help with it.
Thank you. I don't know if you wanted to add anything, Neil.
I could add a little to that, if that's okay. Yes, the issue of burnout is very interesting, because prior to the pandemic, we did some work and established that 36% of doctors in our specialty were experiencing some level of burnout already. And that's before the pandemic. And as both my co-speakers have said, that the pressure under which people have worked during the pandemic in my specialty, so obstetricians, gynecologists and midwives, has been intense. As I said before, pregnancy just does not stop, and they've had to work in all sorts of situations. Having a clean pathway in a labour ward is a very difficult thing to do, and so it's put pressures on quite dramatically. The other information you might find interesting is I spoke in my opening statement about redeployment of staff away from maternity to other parts of the hospital. And as soon as I heard that was going on, we decided to send a quick survey around to trusts, and 53% of trusts had deployed maternity staff into other areas of the hospital. And we're campaigning to make sure that really doesn't happen during the second wave, mainly because in many ways we've learnt from that not being the right thing to do, but also the fact that testing does, as Neil says, give us a little more confidence about the ability of staff in other areas to come back to work quicker. I think self-isolation is a bit of a problem though, because of the length of time that happens for, as I'm sure you're finding with the PM at the moment.
Thank you.
Just to say similar sorts of figures, nothing else to add.
Thank you.
Thank you very much. Lord Russell.
Yes, Saffron, this is initially a question for you, because when we heard from NHS providers back in August, your boss, Chris Hobson, told us that, and I quote, "We absolutely have to develop at pace a fit-for-purpose testing regime." This was in relation to preparing for winter. So as we are now halfway through November and in the second lockdown, what impact on the NHS is the current state of the test and trace regime having on the ability of you to provide non-COVID care?
So I think this is a really important question. There are two things to look at here when we think about testing. So I would separate out general public community testing from staff testing, because they both impact on the NHS, but obviously in different ways. I think that, Chris's words absolutely right. We need effective community testing to get us through the winter, because fundamentally the one thing we can control about this pandemic is the number of people getting it and contracting it, and testing and tracing is focused on trying to identify those people who've been in contact with people who are already COVID positive, so that we can really get that, going back to the original, remember the phrase level, flatten the curve. It's going back to that so that we can get the overall number of cases down. So that's one point. It is absolutely fundamental that that the system as a whole keeps plugging away at getting effective test and trace. I think it's disappointing that it's only reaching, many more people are being tested, but the proportionate level of contacts is going down week on week, so it's only about 60%. That's really troubling, I think. But the other bit of this is staff testing, which I think is a better news story, which is we are hearing all of the news now around the rapid turnaround tests for staff, and also rapid turnaround tests in emergency departments and other places, which are really helping, I think, to get to a place where we can reduce the number of staff who are isolating in particular, and we can identify more quickly staff who are unwell. But I think what I would say is that the testing is critical, but it comes as part of what we might call the holy trinity of testing, of isolating, and then moving to the vaccine. So it's the lockdown, isolation, plus the vaccine and testing all coming together. None of these things is a silver bullet alone. We know that the spread is too wide and the issue is too complex to be treated by one. But winter, huge demand, going to go up. We're going to see many more people coming through the door. We need to get community levels of infection down. That's where we need effective test and trace. But the steps forward in asymptomatic and rapid testing for staff are really positive.
Good. Neil, do you have anything to add?
Only that obviously for both the patients and the staff, if we have rapid turnaround testing, it makes everybody feel much more comfortable. If you have a COVID light site and you have repeated rapid testing, then you have a potentially safe environment for everybody, and it's absolutely essential. And we're very pleased with the latest news.
Good. Edward, any comments?
Thank you. And I just echo what Neil says. I think the confidence of the public in the healthcare system being as free of coronavirus, I think, is the most important thing, certainly from a pregnancy point of view. If a woman who cannot avoid going to hospital because she is in labour knows that she's entering an area where staff have frequently tested, then she will have confidence to come and get the care that she deserves. The other area that's a little more contentious is testing of partners, birth partners that come in labour. And this is something that we are working on with the Royal College of Midwives and with the Department of Health to try and make sure that the partners can come with the pregnant woman on various elements of a pregnancy journey. This is a once in a lifetime event, and we're doing our very best to try and make sure that the right people are with pregnant mums at the right time during pregnancy.
Thank you.
Thank you very much. Baroness Masham.
As cases of COVID-19 further increase across the UK, does it impact the ability to ensure hospital settings are COVID light sites? And also, what about the Nightingale hospitals? Are they suitable and are there enough staff? First of all, could we have the Royal College of Surgeons?
Well, I'm sorry, Baroness Masham, I completely agree with you. We need COVID light sites. We need protected sites in order to be able to preserve elective surgery. We have called for better provision for elective surgery, and that obviously includes the independent sector. We've asked about the Nightingale facilities, but they're not good enough for surgery, for example. The ventilation systems and so on don't work, so they can't be re-provisioned for that. We have talked about a new deal for trying to tackle the great big long wait lists, and that may in due course need extra capacity and funding and extra staff all around it. Maybe we could talk about that later.
And what about the other two excellent speakers, Neil? No, Edward.
Thank you, Baroness. Yes, I completely agree with Neil. I don't have a lot to add here, except that I personally have been operating in the private sector on NHS patients in a COVID light pathway, and that has been incredibly efficient here in Norwich. It's enabled both cancer surgery through the very peak of the pandemic to continue, and as we restore and recover back to more normal service, when the cancer surgery has moved back into the high risk setting of my local hospital, The private sector has continued to allow us to do the less risk benign surgery, again, in a COVID-like setting. So it sort of comes back to my previous point about confidence in the system. If the system is able to run an efficient, reassuring COVID-light environment, which patients really appreciate, I think that has huge benefit to the health service as a whole, and should be supported during the rest of the pandemic until we have more confidence that a vaccine is working, the virus is less prevalent.
Thank you. And Saffron, just to say, there's a terrible problem now of infection in Hull to bring it north. What can be done about that?
Well, I mean, we do know that, I think, in the areas where there are really intensive community prevalence of COVID, we know we're going to see the cases going up in hospitals and in every healthcare setting, and that is a huge problem. I don't know of the specific estate layout and facilities in Hull for all of their healthcare providers, so it's difficult to comment specifically. We know, as Neil said earlier, that trusts who perhaps have a group of hospitals under their auspices can manage to provide that real confidence of the kind of green sites or COVID lights or green zones much more easily than single site providers, and that is a real challenge. However, we are seeing zoning within hospitals as well, red, amber, green zoning. So, you know, red for COVID positive, amber for those who are suspected, and then green for those who don't have it. So there are all sorts of situations and plans put into place to manage that, but often a lot of this comes down to, you know, historical legacy issues like lack of investment in estate infrastructure across different bits of hospital and other provider sites. So that's really important to remember, that this isn't just about how effective people are at the moment in managing that. The thing I would say is that independent sector capacity has played a huge role here, and we would support that. Actually, I think if you ask the independent sector, they were incredibly happy to step forward and help with this. It was everyone to the barricades, really, in order to support the approach. I think if we look at the level of pent-up demand and the need to encourage everyone to come forward to treatment, what we need to be able to do is step forward and ensure that we can follow through on that treatment. I'm not sure, even with independent sector capacity, that that's going to be there for some significant time. Just on your point on nightingales, I think we are seeing them being used in different ways. Is absolutely right, they can't be used for surgery, but I think in Manchester the nightingale is now being used not necessarily for COVID patients, but for other patients in a different way. So just moving different types of patients into different settings where they can be more easily cared for. But the thing we've got to say is one thing, you can build extra capacity, but you can't build extra staff overnight. So, you know, you can put up, the heroics of building the Nightingales was astonishing, and we should really congratulate people, and they're important safety valve. But if we don't have the staff to actually be by those beds and be by those patients, then we've got a real challenge. And just one final point, I know I've spoken for a long time, but we don't have the same level of built-in additional capacity for mental health and community services in the same way. So we don't have the same independent sector contract there. So it's just something to bear in mind when we're thinking about capacity here, which is if we want to come true on our commitments to parity of esteem, let's think about that element as well, because it's not there.
Thank you all for your excellent presentations and your excellent work.
Thank you.
Thank you all. Right, we have 3 minutes left until we go into extra time. So another plea for brevity, as important as these subjects really are. Barbara Keeley.
Thank you, Leila. I want to just ask around the main barriers to restarting elective care, although I guess it's restarting and stopping and restarting and stopping, because I have to say, to add to what was said earlier, in Greater Manchester, we've just seen the halting of all elective care 2 weeks ago because our hospitals were overrun with other cases. So could you talk to us about those barriers and perhaps, you know, what impact on terms of what we already know on further lockdowns due to and spikes in the COVID case rates. I don't mind who starts.
I've got a
Edward.
quick list. Shall I go through my list?
Yes, okay, yeah.
Okay, so there are a whole host of barriers to restarting elective care, but I think we're seeing people doing it as effectively as they can. But, you know, obviously we've got fixed operating theatre capacity, so we need to use that as effectively as possible. Bed capacity, absolutely critical when we're thinking about recovery. So there's not just ITU beds, but general and acute beds when we're thinking about surgery in particular. The issues we've talked about in staff availability, high sickness and absence levels, which are really fundamental. And the final barrier, which we are overcoming now, I think, is rapid point of care and staff testing. But that's going to take a little while to bed in. But I think that's going to really help us on the way to doing what we're probably going to find ourselves doing over the coming period, which is moving in and out of these lockdowns and needing to slow down and start up services kind of on a very, very tight turning circle, really. So the more we learn about this, the better we'll get.
Yeah, Edward, can I come to you?
Yes, I absolutely agree with that. I think this is we're entering a phase now where we thought we were returning to a new normal, but I think the new normal is this dynamic potential for stopping and starting the NHS depending on local prevalence. And I think what NHS managers should be supported to do is to come up with plans about how they can do that without having significant knock-on effects to other aspects of care that they have to deliver. Fundamentally, things that have to continue are emergency activities, emergency theatres and maternity, that they are unavoidable. You can't stop those, as I've said. But I think as Saffron just said, I think the testing and the ability to have reassurance that people can come back to work quickly is going to be one of the most important ways of removing that particular barrier. When it comes to theatre capacity, yes, we have a fixed number of operating theatres, and that is where the private sector has helped. But my back of fag packet calculation about the impact of coronavirus on theatre capacities, it's probably about 40% less efficient than it was prior to the pandemic because of the speed at which pathways move. So if you think that and roll that out through any big trust with 20 operating theatres, that's an awful lot of loss of operating capacity that's happened.
I don't know if Neil, you've got anything to add. I think there's a £500,000 patient waiting list for surgery on hips, knees, and so on. We've heard today.
Yes, so yeah, 30,000 over 52 weeks. Nothing else to say in terms of Saffron's great points and Edward's points. Just to say, I think there is now a political appetite looking forward for there being a separation of emergency, of, if you like, hot sites and cold sites, planned sites. That's going to take a lot of work by a lot of people, investment, all the rest of it. But I think that has to be the long-term solution.
Thank you.
Could I just quickly follow up on that point? Because
you do have to move. I'm so sorry. We really need to move on, or we're not going to finish in time. Baroness Finlay.
Thank you very much. Very briefly, I just wonder what reserve there has been for what you might call the rare specialties, like interventional radiology or blood transfusion technicians, because without a blood transfusion, you can't have an obstetric unit. Without interventional radiology, quite a lot of the neurosurgery type events that need to happen can't happen, and some may be emergency, because these are scarce staff. Once they're off and isolating or off because they're ill, effectively that service is under threat. And I think Edward and Neil would be the two I'd be directing those questions to. Thank you, Baroness. It's a little difficult. I think you said my name first, so I'm going to answer first.
Not an area of expertise of mine, but can I just say that as an obstetrician, the use of blood is a vital resource in maternity, and interventional radiologists, I've long been a big fan, because they can often save a woman's life and avoid the need for really serious surgery if she was to have a massive bleed after delivery of her baby. And certainly they're specialties that I wholeheartedly support. But I'm afraid I can't answer your question other than to be a fanboy for the question.
Me neither, unfortunately. I have a daughter who's an interventional radiologist. It's all part of the big team picture, isn't it? They're all interlocking. It's like a fragile ecosystem, as I describe it. One little bit of it goes down and the whole thing falls down. And that's why we need all the things we've been talking about, the testing and the COVID light sites, etc.
It just strikes me that these are small but absolutely essential cogs, and if one of those goes out, the whole machine collapses, and I'm not sure that we've built in enough reserve. Thank you.
Yeah, Saffron, do you have any insight there?
No, I don't know about the specifics of this, apart from to say that, you know, if at a larger scale, you know, we see that even, you know, when we see an anaesthetist go down, that has a massive domino ripple effect. So when we're thinking about things that are very highly specialized, we can only imagine that it's more intense and will have fundamental challenges, because there aren't so many of them to replace. So that's, you know.
Yeah, thank you very much. Dr. Philippa Whitford.
Thanks very much, Leila. If I could start with Neil, obviously we've talked about getting elective services going, although my specialty of breast cancer locally, they did manage to keep working to some extent. But what about the backlog? I mean, staff are exhausted. You mentioned the drop in theatre capacity. How can we actually catch up that backlog? And I'm starting with you, just your comment about ventilation in the Nightingale units, I found was really kind of rather worrying, in that they were designed with the idea of having COVID patients there, perhaps using CPAP. Does that not make them quite a dangerous environment if you feel the ventilation isn't up to scratch?
The ventilation I was mentioning was not, if you like, intubated ventilation or CPAP, but the ventilation that's specially required, the special flows that are used in theatres for infection prevention and control, which is obviously slightly different. The Nightingales can't do that.
Right, so you meant laminar flows like in orthopedics.
Yeah.
Okay. What about the whole issue of how we're going to catch up the backlog? I mean, in lots of specialties, it's difficult to see enough people in clinics or treat them because of PPE, of having to leave fallow time, again, because of ventilation and the risk of aerosols. Have you any suggestion of how the backlog is going to be caught up?
Not simply, to be quite honest, not without a massive effort, not without a new deal, not without a national strategy. You know, if theatres work 7 days a week, 24 hours, and all the staff did too, they'd all be exhausted very quickly, and you know, there'd be nobody there to do the work. It's a massive, massive problem, and there needs to be some kind of national solution, I think.
Yeah, as you said earlier, it's not just the space; it's staff is the kind of pinch point. Edward, any comment? I know obviously you're more on the maternity side.
From the gynecology side, I do completely support what Neil just said. I think you could say, well, let's have a 7-day service, but that needs to be designed very carefully, because it spreads that same resource thinner. And so one has to really plan that very carefully and have staff on side. We've had this all hands to the pump effects for the past 7 or 8 months, and everybody has been very happy to contribute to what has been an enormous national effort. And I'm fantastically grateful to everybody who's gone the extra mile during this time. But I think we can wear people out, and as we started this discussion on burnout, it's quite prescient to end on the burnout issue, we cannot afford to stretch our staff too much. They fundamentally are still worried about the environment that they're working in, and especially our BME NHS staff. They are at higher risk. There are inequalities in the care that they receive, and inequalities in the outcomes they get from COVID. And I think it's really important that they are supported and their needs are recognised. They contribute a huge amount of work to the NHS staff cohort, and I think it's very important that if we start to work people over a 7-day week, that it's very, very carefully managed. And there's a greater strategy to plan this, I think, is exactly, agree with Neil.
Finally, Saffron.
Yeah, I think this is an absolute, how we're going to tackle these backlogs is an absolutely critical point. And I think what I would draw your attention to is the fact that old problems, just because we're in a pandemic, old problems don't go away. So one of the things we need to really focus on is, flow of patients through hospitals. Just because we're in COVID land doesn't mean that we're not going to have delayed transfers of care, etc. So we need to make sure that we're really smartly, smoothly focusing on supporting social care, move out into the community, out of hospital, making sure that flow is there. And then thinking also about how we bring the extra capacity in, continued contracts with the independent sector. The points on burnout, fatigue, not working people 7 days a week is absolutely critical. But, at the end of the day, Rishi Sunak said in the budget at the beginning of this year, that the NHS would get everything it needed to tackle COVID. Well, I think that's going to be quite a big chunk of money that is needed to actually implement a national and local strategy to get through the backlog, to encourage people to go to their GP to get potential diagnosis as well. So it's not just about what we're seeing in terms of backlog now, it's future backlog as well, due to lack of referrals, lack of diagnostics, etc. So there's a big conundrum of issues there. But let's remember the old problems are still here.
Thank you very much, Chair.
Thank you very much, all of you. Well, that draws our session to the end. I particularly want to thank our witnesses and their pets for joining us today. It's been a really lovely. She's lovely. The more of that, the better. I'm very, very grateful for your time. Thank you for spending extra time with us as well, over and above the time that we'd allotted. But I think it was absolutely right to continue with the questions. It does feel very much like we're just scratching the surface of a new problem, and your calls for what we should be asking for in the spending review, I think, have been heard loud and clear by many parliamentarians across the whole House in both places. So thank you very much for your contributions today. So Saffron and Edward and Neil, thank you for your time. Thank you to all parliamentarians for their questions, and thank you to all at home who have been watching this. This is the last of the live evidence sessions we are intending to have this side of Christmas, although if a special occasion arises, no doubt our very active group will come back together, and coming soon will be the list of recommendations that we are putting together off the back of these inquiries. So thank you all again, and I'll draw this session to a close. Goodbye, everyone.